गुड आफ्टरनून।
गुड आफ्टरनून डॉक्टर नितिन।
सर गुड आफ्टरनून सर।
कैसे हैं आप?
सर मैं ठीक हूँ सर।
तो
आप
ऐसा
कैसे हैं?
है, अभी 5 मिनट में शुरू करते हैं। थोड़े बच्चे और आ जाएं क्योंकि बच्चों को पता नहीं है कि बहुत महान शिक्षक आ जाए, 5 ईयर फेलो।
अरे सर आप सर। अरे सर सर।
और क्या। नहीं नहीं, वैसे भी आप बहुत सॉट आफ्टर टीचर हो, आई नो, बट स्टिल लेट्स ए
नहीं
फ्यू
सर।
मोर पीपल ज्वाइन।
अरे सर। सर आपके शिष्य है सर। बस
आप
इतना
सारे
जरूर।
में बैठे हो तो यहीं आ जाओ, चाय पिला देते हैं। अकेले वहां पे क्या कर रहे
नहीं
हो? हम
सर,
लोग।
घर पे सर, घर से सेशन ले रहे हैं सर।
अरे घर पे तुमने पूरा वो बनाया हुआ है, सारा कैबिनेट वगैरह पीछे। चलो कोई बात नहीं।
नहीं सर, सर ये बालक का कमरा है तो बालक, दोनों बालकों के कमरे में बैठ के हम सेशन ले रहे हैं।
दिस इज नॉट राइट, यू शुड नॉट स्टडी इन चिल्ड्रंस रूम। वेयर विल चिल्ड्रन स्टडी देन?
सर चिल्ड्रन प्लेइंग, नो स्टडिंग।
चलो ठीक है, कोई
गुड
बात
आफ्टरनून सर।
नहीं। इम्पोर्टेंट।
गुड आफ्टरनून सर।
गुड आफ्टरनून पीयूष सर।
हाँ।
आप स्टूडेंट हैं आज?
सर हम सुनने आए हैं सर, और क्या।
ये क्या
आपने
बात है।
बताया सर फेमर के टीचर पढ़ा रहे हैं, तब सुनने आ गए।
हाँ, आप दोनों बिल्कुल जुगलबंदी अच्छी है। आप दोनों
सर।
एक दूसरे को पढ़ाते रहते हो, हमें भी पढ़ा दिया करो।
सर ये जो डॉक्टर साहब है सर, ये सीनियर फेमर है ना, ये देखने आए जूनियर ठीक पढ़ा रहा है नहीं पढ़ा रहा है।
ये भी बात सही है। चलो 2-3 मिनट इंतजार करते हैं, अभी तो 4 बज के 1 हुआ है। 5 मिनट इंतजार करते हैं, थोड़े बच्चे और आ जाते हैं।
जी सर, जी
ठीक
सर।
है।
ठीक है सर।
हाँ। Good afternoon, Dr. Nitin. I think we can start if you are available. Ready? A very good afternoon, everybody. So we have the next topic today, hyponatremia, in the series on clinical medicine. And we have a very senior professor, Dr. Nitin Sinha, who has just completed his fellowship in FIMER in medical teaching. And he is at Atal Bihari Vajpayee Institute of Medical Sciences. Although his slide mentions only Professor, Department of Medicine, he is also the Dean, Vice Dean out there at RML Hospital and Atal Bihari Vajpayee Institute of Medical Sciences. And he's a very experienced clinician and has a very good command and very popular among his students. So I request Dr. Nitin Sinha to please start today's proceedings.
Uh, Good afternoon, everyone. And at the very outset, thank you, Dr. Anupam sir, for all these kind words. And all this is because people like sir have been my teachers. So I have whatever I have learned is from such brilliant teachers. So today the topic is hyponatremia. And I think all of you would agree that this is one of the most common electrolyte abnormalities apart from potassium disorders, which is commonly encountered by the physicians all across, whether they are working in medicine ward or in critical care or in ICUs. So this is a common problem which you face, and sometimes there may be certain things like how to manage such patients, whether it is pseudo hyponatremia, whether it is true hyponatremia. So all these things we are going to discuss in today's lecture. What I will do is I will speak up for around 40 to 45 minutes, and the remaining 10 to 15 minutes we can invite questions from all of you. You can send the questions as chat, or you can even switch on your audios and you can ask me. So commencing with hyponatremia. So at the very outset, I have taken this presentation or whatever material I'm going to present you from all these three references. These are the main references. Apart from this, certain articles on the internet were also taken help of, so that I could have prepared this entire presentation. So the basic concept first, that what is hyponatremia? When the serum sodium is less than 135 milliequivalent per liter. The normal values we all know is around 135 to 145 milliequivalents per liter. Now, based upon the levels of sodium, it is classified as mild, moderate, and severe. Mild is somewhere around 130 to 134. When it is 125 to 129 milliequivalent, it is called moderate, and less than 125 is severe. There is another classification for hyponatremia, which is called acute or chronic. Now, whenever we have a history which suggests that the hyponatremia could have occurred in the last 48 hours, it is called as acute hyponatremia. And when there is history which suggests that, or probably there is whatever we get in history and examination suggests that it is more than 48 hours, then it is called as chronic. However, if on the basis of history, it is, the doctor is unable to classify as to whether it is acute or chronic, it is treated as chronic, not as acute. So these two things should be clear before we proceed further. Now, coming to the symptoms. Now, you can see that patient can be asymptomatic to having severe symptoms. So it can present in a spectrum. So asymptomatic patients are usually those who don't even know that they have hyponatremia. It is only on routine blood tests when they are found. And if somebody wants to test them further, there are certain neurological tests which are there from which you can find out that they may have some bit of neurological disturbance. But most of the times in their routine day-to-day work, they don't have those symptoms for which they will consult a physician. Coming to mild symptoms, headache, irritability, altered mood, poor concentration, and depression. Coming to moderate symptoms, these becoming little more severe in the form of confusion, disorientation, altered mental status, unstable gait, repeated falls. So one of the common causes for repeated falls is hyponatremia. Severe symptoms actually are vomiting, seizures, obtundation, respiratory distress, and to the extent of coma. So this slide actually explains how the symptoms can be there in a hyponatremic patients. Now, coming to the European classification, they use another term which is called as moderately severe. Now, what they mean with moderately severe is that the other terms, they are mainly from the US guidelines, but the European guidelines, they mention as moderately severe and severe. So what is moderately severe is when they have nausea, vomiting, confusion, headache, they are called to be having moderately severe. And if vomiting, respiratory distress, abnormal or deep somnolence like coma, seizures, or Glasgow scale less than 8, then they are considered to, patients are considered to be having a severe symptoms of hyponatremia. So there is slight difference between the two guidelines in the form of their nomenclature of the severity and what all symptoms they include in severity. But you will see that in severity, the symptoms are mostly the same. Now, there are certain important points to remember here and now, that the serum values of sodium and symptoms do not always correlate. Patient might be having a sodium of 125 and might not be having symptoms suggestive of severe hyponatremia. As we discussed in the very second slide, that sodium less than 125 is severe hyponatremia. But it does not mean that if a person has severe hyponatremia, which is based on the values of serum sodium, the same person is going to have severe symptoms of hyponatremia. So the symptoms will not correlate with the levels of serum sodium, might not correlate with the symptoms of serum sodium, so levels of serum sodium. So coming to the treatment and diagnosis of etiology of hyponatremia, they both go hand in hand. So when a patient presents to the emergency or is critical, it's not that we start finding the cause first and we treat later, or we start treating first and we leave the cause, finding the cause to a later time. They both have to go hand in hand. So once this is clear, we move to a approach to a case of hyponatremia. I think we as physicians, rather than going into the pathophysiology and everything, we would like to approach how to make a good approach to a case of hyponatremia. Once we are clear with that, we will be able to manage the patient much better. So history. In any case in medicine, history is very, very important. As I told you in the initial part, that acute and chronic. Now, acute and chronic, we can only get through history. If we have a good history taking, if suppose somebody has taken excessive beer, excessive amount of water in last 48 hours, the symptoms if he is having and he is having hyponatremia, maybe because of acute hyponatremia. Sudden amount of volume loss in the form of diarrhea, vomiting, where the volume loss and sodium loss both have occurred. And sodium loss is more than the volume loss, which is hypovolemic hyponatremia. We will discuss later. Again, if it has happened suddenly, it is acute hyponatremia. Now, coming to medication, history of medications is very important in such patients. It is because in these patients, they may be on certain drugs which can produce hyponatremia. Especially, most common example we take is of diuretics. However, there are other drugs like chlorpropamide, carbamazepine. So these are the drugs which can produce hyponatremia if taken in excessive doses and all. Patient who is an alcoholic, patient who has had surgeries in the past, all these histories are very important in a patient of hyponatremia. They will give us some clue towards the etiology of hyponatremia and whether it is acute or whether it is chronic. Now, general physical examination. So after history comes the examination where we just assess the volume status, whether the person is hypervolemic, euvolemic or hypovolemic. And we all know that whether the blood pressure is low, if the mean arterial pressure is low, there is tachycardia, there is cold and clammy skin, then it is loss of volume or hypovolemia. Hypervolemia means there is pedal edema, there is third phase correction in the form of pericardial effusion, pleural effusion, ascites, facial puffiness. So all this suggests that patient is having hypervolemia. So hypervolemia, hypovolemia, and if nothing is there, then it is probably euvolemic. So that is how what we decide on the basis of a general physical examination. Investigation, sodium is low. There are three more investigations which we have to do, which will help us to find the cause or will help us to lead to a cause of hyponatremia. One is plasma osmolarity, urine osmolarity, which is spot sample, and urine sodium excretion spot sample. So these are investigations which are required to lead us to a diagnosis of a hyponatremic patient as to what is the cause of hyponatremia if it is not clearly evident from the history. Other investigations are also important. We are just not bothered about how much sodium is there and what is the type of hyponatremia the patient has. there are certain other investigations which are equally important in a patient of hyponatremia. And what are these? These are plasma glucose, lipid profile, and certain routine investigations like kidney function test and liver function test. Why they are important, we will discuss with a case in the next slides. So we will realize the importance of these investigations in these places. Why we are getting these done. In certain cases, serum protein electrophoresis, thyroid function test, 8 AM cortisol, even workup for malignancy, sepsis. So this will depend upon the patient condition and other investigation need to be carried out. So now let us go to management of a patient of hyponatremia. How do we manage a patient of hyponatremia? Considering that we now know that what is acute and chronic, we now know what is mild, moderate, and severe hyponatremia based on serum sodium level. We know the symptoms of hyponatremia, which can be mild, moderate, severe, and we know that what history examination and what investigation need to be done. So now we move to the management. Now, how do we manage a case of hyponatremia? So step one, your first step is to rule out hypertonic and isotonic hyponatremia. So what is hypertonic hyponatremia? So our first step, let us go step by step, and then we will try to find out how do we manage a case of hyponatremia. So firstly, what is hypertonic hyponatremia? See, there are three types: hypertonic hyponatremia, hypotonic hyponatremia, and isotonic hyponatremia. So what we see mostly in our clinics, in our ICUs and critical care is hypotonic hyponatremia. But that is the most common. But that does not mean that isotonic hyponatremia and hypertonic hyponatremia don't exist. They are very commonly seen. So let us discuss them out. So in hypertonic hyponatremia, as the name suggests, the serum sodium is low, it is hyponatremia, and hypertonic means that the plasma osmolality is more than 295 milliosmol per kilogram of water. That is, it is high osmolality. Normal osmolality, since it's not an interactive lecture, the normal osmolarity is 280 to 295. Otherwise, I would have asked the audience that, okay, tell me what is the amount of, what is the normal plasma osmolarity. But now it is more than 295. So what are the causes of this high osmolarity? Hyperglycemia in the form of diabetic ketoacidosis and non-ketotic hyperosmolar coma or non-ketotic hyperosmolar syndrome, giving mannitol, glycine, which is used in urological procedures, some hyperosmolar radio contrast agents, maltose. So please keep this in mind that these are the reasons why hypertonicity of the plasma can occur, and this can lead to hyponatremia. Now, we commonly encounter DKA and NKHS. You all will agree that diabetic ketoacidosis and non-ketotic hyperosmolar coma are very commonly encountered in our emergency settings and even in ICU settings. So, there is a correction formula for hyponatremia if there is hyperglycemia. Now, the corrected sodium is measured sodium plus 2.4 into glucose, which is measured minus 100 divided by 100. So, that is the sodium which you have to correct. So this is a correction formula, like something we do for calcium and albumin. There is something which is there for hyperglycemia and sodium also. So this needs to be kept in mind. Now, let us see a case. Now, this is a case of 55-year-old diabetic. You will realize that this is a very commonly encountered case. 55-year-old diabetic who missed his insulin dose twice and presented to the emergency with complaints of vomiting, abdominal pain, and deep somnolence. His investigations revealed a serum sodium of 123 milliequivalent per liter and plasma glucose of 600 milligram per deciliter. His serum osmolality was 304 milliosmol per kilogram of water with no urine ketones. Now, here comes the big question. This patient has low sodium. Serum sodium is 123. That means he is having severe hyponatremia based on serum sodium values. Now, coming to symptoms, he is having deep somnolence, vomiting. So he is having severe symptoms of hyponatremia. So do you think he requires a 3% normal chloride? I am assuming that we all know what is 3% sodium chloride. So do you think he requires a 3% sodium chloride? He is having severe hyponatremia as well as severe symptoms of hyponatremia. So do you think he requires? So, but firstly, let us see whether it is hypertonic hyponatremia or not. See the amount of glucose. The glucose is 600 milligram per deciliter. So now the first step should not be to jump to 3% NaCl. It should be to first correct the sodium for blood glucose, as we mentioned in the previous slide. So since the osmolality is high, the glucose content is high, we should not jump to hyponatremia treatment immediately. The first step will be to correct sodium for blood glucose And if I apply the formula which I have shown in the previous slide, this sodium will come out to be around 135 milliequivalent per liter, which is normal. So actually, we should not be giving this person 3% NaCl. So this is what is the importance of hypertonic hyponatremia. So do not run after this patient. Rather, this all symptoms can be because of NKHS, because urine ketones are negative. This probably is NKHS, and the patient needs management for NKHS. The other abnormalities will automatically correct. So this is one case which I have told you. Now, coming to the next entity, which is called as the isotonic hyponatremia, which we popularly also called as pseudo-hyponatremia. You will find this term pseudo-hyponatremia written in many of the books, but sometimes at some places they don't actually mention what is pseudo-hyponatremia. So it is actually isotonic hyponatremia. That is, the serum sodium is low, osmolality is normal, 280 to around 290 to 295 milliosmol per kilogram. Now, what are the causes of this isotonic hyponatremia? It is elevated total cholesterol or low density lipoprotein cholesterol levels, elevated proteins as is seen in multiple myeloma. So there are certain investigations I told you which are important along with the investigation which we want to do to rule out causes of hyponatremia, to find the causes of hyponatremia. And if I just take you back to this slide, please see this is plasma glucose, lipid profile, and routine investigation like KFT, LFT, serum protein electrophoresis, thyroid function test. Now we'll come to the thyroid function test later, but this is the importance. So glucose for hypertonic hyponatremia and total cholesterol, low density lipoprotein cholesterol level, elevated proteins as in multiple myeloma. But patient should be fitting into a multiple myeloma. It is not that we get protein levels done or this gamma spike done for every patient of hyponatremia. No, it has to be a case specific approach. But what I wanted to highlight is that these also lead to hyponatremia, and these are actually false hyponatremia. There is no hyponatremia actually. These agents, they actually cause problem in the measurement of sodium by the method which they use, which is flame photometry. Most commonly, it is flame photometry where they use, and these actually lead to hindrance in the measurement of sodium by that method. So in those cases, there is an ion method to measurement sodium. If we request the biochemistry people, if we know that this is the condition of the patient, and if we know, then we can request the biochemistry person so that they can recheck the sodium and with a different method. Or we can very well understand that probably this is an artifactual hyponatremia and we need not bother much about it. So this is isotonic hyponatremia. So once hypertonic and isotonic hyponatremia are ruled out based on the history, based on the patient's condition, based on examination, based on the investigation which have been done, then we come to the most important part of today's lecture, which I think everybody wants to know about, is hypotonic hyponatremia. So what is hypotonic hyponatremia? It is low sodium and low serum osmol or low plasma osmolality, which is less than 280 milliosmol per kilogram of water. So let us now concentrate on the steps of management of hypertonic hyponatremia. So just to take a break in between, if anybody from the audience has any questions till now, anybody from the audience, whether they can either put in the chat or they can just unmute and they can ask. So is the concept of hypertonic and isotonic hyponatremia clear? So somebody has written yes, sir. So I am thankful. Dr. B. Darshan Koyal, thank you. So I will proceed further. I think for rest, I assume that it is clear and they are not in a state of hyponatremia. So coming to the management of hypertonic hyponatremia. So as I told you in the general physical examination, we have to assess the volume status. Now, as I've already told you how it is to be done, I'm not going to repeat it. But assessment of volume status, along with the investigation which we have done for sodium, serum sodium, urine osmolality, serum osmolality, and urine spot sodium. So we have reached this place where we already know that the serum sodium is low. We already know that the serum or the plasma osmolality is low. So now what the other two investigations will help? Urine osmolality and urine spot sodium. So let us find out. This is very well evident in this slide. So let us go to firstly hypervolemic. That is, the volume status is more. That is, yes, that the patient has pedal edema, third space collection, patient has hypertension, maybe hypotension, whatever the thing is, and there is elevated jugular venous pressure, facial puffiness. So all these are suggestive of a hypervolemic state. Now, if in hypervolemic state, if a patient has low sodium and low osmolality of plasma, and the urine osmolality is high, that is more than 100 milliosmol per kilogram of water, and urine sodium is less than 30 spot sodium, then it suggests cirrhosis, heart failure, nephrotic syndrome. However, if the urine sodium is more than 30 and osmolality is more than 100, it suggests renal failure. So these are some interpretations we can make out based on the investigations we do. Similarly, for euvolemic, if urine sodium is more than 30, urine osmolality is less than 100. That is the kidneys excreting more amount of free water. That is the osmolality is less. It is mainly because there is excessive ingestion of fluids, primary polydipsia, or there is a beer potomania, excessive amount of beer intake. And if the osmolality is more than 100, it can be because of SIADH, hypothyroidism, and glucocorticoid deficiency. So here the importance of TSH and 8 AM cortisol comes, which I told you are edit investigation, which we do. And SIADH, if there is a SIADH, then we have to look for any intracranial lesion, mass lesions, any pulmonary involvement, any malignancy, any mass lesions. So all these will come under the workup of SIADH if the patient has low sodium, low euvolemic, low plasma osmolality, high urine osmolality, and urinary sodium is more than 30. So that is how we reach it. And then comes to hypovolemic, where the urine osmolality more than 100 and less than 30 sodium, it is vomiting, diarrhea, or third space collection. And if more than 30 sodium, it can be because of diuretics, salt wasting syndromes. So this is a rough, or you can say kind of a classification to reach a diagnosis or to inch towards a diagnosis of hyponatremia. So how do we treat? So it is not only the cause, it is the symptoms which guide, and it is also the duration of hyponatremia which guides the treatment. So there are two important things: acute, chronic, mild, moderate, severe symptoms, and sodium. So this is how we have to proceed. So you have to take both these agents, whether it is duration or though, they actually, kind of influence the treatment of the patient. So let us go to another case. A 60-year-old gentleman, an alcoholic with weight of 70 kilograms, presented with complaint of deep somnolence and seizures. So seizures are there, so it means that the patient is having a severe symptoms. For last 5 to 6 hours, after thorough examination and some basic investigation, serum sodium was found to be 118 and plasma osmolarity was 275. That means he is having low sodium, severe sodium deficiency, he is having severe symptoms, and he is having a hypotonic plasma. So he is hypotonic, hyponatremic patient. So now we have to assess the volume status, whether he is euvolemic, whether he is hypervolemic, or whether he is hypovolemic. So now we have to first evaluate this thing, find the cause of the hyponatremia, and we have to give treatment also. Now here the important things come. He is having seizures. He is having somnolence. Do we wait for all the other investigations to come? No. We know that the sodium is low and he is probably hypotonic hyponatremia. So we have to start the treatment 3% NaCl simultaneously along with other investigation which can help to find the cause of hyponatremia. So the both things go hand in hand. That was the first part I told you in the initial first 2-3 minutes of my presentation, that treatment and diagnosis, they go, and finding the cause, they all go hand in hand. Now, coming to acute symptomatic hyponatremia. Now, acute means less than 48 hours. And patient is having symptoms. Now, how to treat? Now, acute symptomatic hyponatremia, as per the United States guidelines, is severe symptoms if 3% LS bolus is given. 100 ml is infused over 10 minutes. And not more than 3 bolus is advised. So here is the role of bolus. In most of our practice, what I had learned during my initial formative years in the medicine is that we never used to give bolus of NaCl. We would give infusion of NaCl, fearing that it could lead to osmotic demyelination syndrome. So this was a fear. But over the time, when I read and when we realized, it is very well there that people give boluses of 3% NaCl for different reasons, also for raised ICT also. So there are different reasons, and we should not be bothered much about if we give boluses for osmotic demyelination syndrome. If it is acute hyponatremia, we are not talking about chronic. Acute hyponatremia less than 48 hours, typical history. What history can be there? I'm again repeating: excessive fluid intake, excessive beer intake, sudden symptoms, and patient is having, or there is severe vomiting, diarrhea, loss of volume with more excessive loss of sodium. So these are the cases of acute symptomatic hyponatremia. And you will realize that most of them will fit into the criteria of hypotonic hyponatremia. Hypertonic and isotonic usually do not manifest as acute symptomatic hyponatremia. So that is how this is. What is the slide? If somebody wants to take a picture, they can take. Even if we go to the European guidelines for severe symptoms, see, they had two symptoms, moderately severe and severe. They again recommend infusion of bolus doses of around 20 minutes of 150 ml. Here it is 100 ml over 10 minutes. Here it is 150 ml over 20 minutes. They further give, European guidelines further give that in next 1 hour, sodium increases more than 5 milliequivalent per liter, stop 3% unless and continue other cause-specific management. However, if there is no improvement, give continuous infusion of 3. So here comes the role of 3% NaCl after one bolus. So the two guidelines differ in their approach. You can adopt either one of them, and either one of them is equally effective. One guideline was published in 2013, the European one, and the US ones came in 2015. So they are both equally acceptable at different parts, in different parts of the world. So here comes the importance of correction. So in European guidelines, they say that serum sodium correction should not exceed 10 milliequivalent per liter in 24 hours, and should not not to exceed 8 milliequivalent per liter in next 24 hours. So they clearly define how much sodium is to be corrected in 1 day or in next 2 days. Here in US guidelines, they actually say that you can correct to a certain level. They do not exactly classify as to how much can be corrected in acute symptomatic hyponatremia. I'm not talking about chronic. I am reinforcing it again and again. This is for acute symptomatic hyponatremia. So here they rather say that in US guidelines, there's no need to restrict rate of infusion or correct overcorrection. Once sensorium improves, shift the other to other treatment modalities and look for the cause of hyponatremia. So here they're given an emergency treatment and they now want to look us for the cause. And remember, ponivaptan or tolvaptan, the two commonly used vaptans, are not at all indicated for management of acute symptomatic hyponatremia. So this should be very clear in either of the guidelines. Now coming to chronic hyponatremia, here we have to correct sodium, but it is very different from the way we approach an acute patient. Here, there are chances of osmotic demyelination because the sodium low level is persisting in the body for a very long time. So that is why the chances of having ODS, that is osmotic demyelination syndrome, are high if correction is done fast. There we were correcting fast in acute, but here if we do a fast correction, it can lead to ODS. So there are limits of correction. So what are that? So for low risk ODS, it is 10 to 12 milliequivalent per liter in 24-hour period and 18 milliequivalent total in 48 hours. And for high risk ODS, not more than 8 milliequivalent liter for any 24 hours. Now, what is this low risk and high risk? Who are at low risk and who are at high risk of developing ODS in chronic hyponatremia? Let us find out. Now, if a person is having a sodium of less than 105, has concomitant hypokalemia, alcoholism, or is having malnutrition, or is having an advanced liver disease, these are the patients who are likely to go into osmotic demyelination syndrome. So if a person has hyponatremia, which is chronic and in which there is high risk of developing ODS, then please don't do correction of more than 8 milliequivalent per liter in any 24 hours. So first, see your patient, identify his chronic hyponatremia, and if he or she is chronic hyponatremia, whether they are at high risk of ODS or not ODS, or high risk. If they are at high risk, please restrict your correction. If they are not at high risk, then you can correct to 10 to 12 milliequivalent per liter in 24 hours period and 18 milliequivalent in total in next 24 hours. That is in total 48 hours. So let us go to another case. A 46-year-old male chronic smoker and alcoholic complains of hemoptysis. He also had headache and poor concentration for last 1 month. So he is having some symptoms of hyponatremia, headache and poor concentration. So these are actually mild symptoms, headache. See, he has low sodium and he also has, now look at the duration of symptoms. It is for 1 month. So he's most probably having chronic hyponatremia. Low sodium, 126, and he's also on investigation found to have small cell carcinoma of lung. Now, he was given tolvaptan. After 24 hours, his sodium was 138 millicurie per liter and his tolvaptan was stopped. On 7th day of admission, he developed quadriparesis and a locked-in state with mutism. Repeat sodium was again normal. So what has happened to him? What has happened to him? His MRI brain was performed. I am just telling you in a very short brief what happened to this patient. This is little blurred image. Actually, I wanted to correct it, but somehow I could not get time. But look at this central pontine area. It is suggestive of osmotic demyelination syndrome. He also diagnosis of ODS was made. What happened was his sodium was corrected too fast. He was having chronic hyponatremia and he was having a high risk of developing ODS. Why? Because he was an alcoholic and he was malnourished. So that would be the reasons why he went into ODS. He was at high risk of ODS. So here the correction should have been very, very careful. So that is the importance of having identifying patients who are at high risk or low risk of ODS and then correcting the sodium. So ODS can occur even some days after hyponatremia correction. This case highlights that fact also. It is not immediate. It can occur after some days also. So this is the importance of putting this case to you that chronic hyponatremia identify whether they are low or high risk of ODS and then treat. Now coming to euvolemic hyponatremia. Now we are discussing the causes of chronic hyponatremia or the etiologies of chronic hyponatremia. We will proceed euvolemic, which is most commonly encountered apart from hypervolemic one. Hypovolemic hyponatremia is encountered much less. So we will discuss that in the last. So euvolemic hyponatremia. So we have discussed certain causes. It can be SIADH, it can be glucocorticoid deficiency, it can be hypothyroidism. So once you have a chronic hyponatremia patient who is euvolemic hyponatremia, his osmolality plasma is low, his urine osmolality usually will be more than 100 milliosmol per kilogram, and his urine spot sodium will be usually more than 30. Please investigate him further for SIADH, hypothyroidism, and glucocorticoid deficiency. There are certain other conditions also. I have not purposefully put them because then it will make rare things included into it. I tried to keep more focus on the commonest things which we encounter in our normal practice. So there are a number of causes of SIADH. Stop drugs that can lead to SIADH, which can be chlorpropamide, carbamazepine, and certain other drugs. Transient conditions which can lead to SIADH like post-operative hyponatremia, pneumonia, meningitis, they can have correct hyponatremia correct spontaneously. SIADH can last for 1 to 3 weeks. It can even last longer. And you have to treat hyponatremia if there are symptoms, and you have to simultaneously look for the cause of the SIADH and treat that cause. If there are brain tumors or if there are certain tumors which produce arginine vasopressin, or you can say vasopressin or ADH, then SIADH can last even for years or for an year or maybe for more months. So long-term treatment of hyponatremia is required in such patients. So now how do we treat? Now we know that SIADH is there. We are looking for cause of SIADH, but what about sodium? How do we manage sodium? So the first thing is fluid restriction. So restrict all fluid intake and not just water. So it is very important that you test पानी नहीं कम करना है, सारे तरल पदार्थ को मिला के the intake should be less than 500 ml of the total 24-hour urine output. Now, what are the predictors of failure of fluid restriction? There are certain factors. I am not going to detail out of them. These are mentioned. If somebody wants to take a snap, they can snap. But if these are present, if you have started the patient on fluid restriction and if these are present after maybe some days, that means the fluid restriction is not working. So just asking the patient to have fluid restriction is one thing, and then monitoring that patient for sodium, another thing is also equally important. So if fluid restriction fails, then what are the other options? One is dimeclocycline, which is 600 to 1200 milligram per day. It causes nephrogenic forms of diabetes insipidus, but several days of treatment is required for maximum diuretic effect, because you have to remove that excess volume or excess fluid from the body. That is why this dimeclocycline is used. Urea is also used, but it can lead to severe azotemia and poor palatability, so it is not that common. Coming to the commonly used agent, which we all know are being used, is conivaptan, which is used IV, and tolvaptan, which is used orally. Now, tolvaptan is B2 receptor antagonist. Conivaptan also acts on B1A receptors. Then it is both of them are contraindicated in acute hyponatremia and hypovolemic hyponatremia. And they should not be used in other treatment with other treatment modalities like fluid restriction. So it is only when the fluid restriction in SIDH is failing or is not effective, then only this can be used. So the first step is fluid restriction. So this is how it all goes. And nowadays the tolvaptan which is used is given in a dose of 15 to 30 milligram per day. In most of the literature, you will find that it should not be given to more than 30 days. But there have been studies where they have shown that it can be given for a longer period. I was just going through before I was preparing for this lecture. I went through certain article where they've been using it for a year and a half. And but the what important point is that they closely monitor the liver function test because it can lead to liver damage. So they closely monitor the LFT and it can be given for a longer duration. So the most of the literature you will find is for not more than 1 month, but people are using it. And yes, this Piyush will remember that just 2-3 days back we were discussing one such patient, and Piyush said that no, we can use it for a longer time. So luckily I was reading about it, so I am just trying to present it here. So we can use it for a longer time. So here is hyponatremia with glucocorticoid deficiency. Here the early morning cortisol or the steroid is measured, which is less than 18. But remember that in acute conditions, the steroid should have risen. If in acute condition, severe condition, the steroid is normal or the glucocorticoid is normal, it again suggests that there is an adrenal insufficiency. So normal for normal is okay, but for acute condition, if the glucocorticoid or the cortisol is coming normal, then again it is suggestive of a adrenal insufficiency and further workup needs to be done. And here for hyponatremia, only steroids are given and they will automatically lead to the improvement. Hypothyroidism causing hyponatremia is there, but here the importance is you can put fluid restriction, but the major treatment is thyroid hormone replacement. Once it is getting replaced, other things start getting automatically corrected. Now coming to one more common part, which is hypervolemic. So it can occur in congestive heart failure. It can occur in cirrhosis with hypoalbuminemia and ascites and other pan body edema or panasarca. Then it can occur in renal failure. So whenever there is volume overload, then hyponatremia can occur. So now how to manage that? So if there are severe symptoms, we give 3% sodium chloride and diuretics. If there are mild to moderate symptoms, we give fluid restriction is the treatment of choice. And if fluid restriction fails, then we add Vaptans to them. And Vaptans have to be added with LFT monitoring. So this is how it all goes. And diuretics may be stopped, but many a times this may not be possible. So we have to, this is a condition where both diuretics and probably they can be used. We have to minimize the dose of diuretics if it is leading to hyponatremia. So these are challenging situations which have to be managed case to case basis. So coming to another form of hyponatremia, here the symptoms, if they are severe, again 3% NaCl plus diuretics. Mild to moderate symptoms, again fluid restriction, and you can adjust dosage of diuretics, and then Vaptans can be added. So now if there is impaired renal function, tolvaptan and conivaptan, please remember that they are not recommended if the creatinine clearance is less than 30 for conivaptan, and for tolvaptan if it is stage 5 CKD or creatinine clearance is less than 10 ml per minute per meter square. So in these cases, fluid restriction is the treatment of choice, and this has to be catered to. Coming to the one of the least common encountered problem is hypovolemic hyponatremia, where the volume loss is there, sodium loss is there, and sodium loss is more than the volume loss. So most commonly this occurs if there is acute diuretic, diuretic has been started, high dose diuretics, or maybe profuse vomiting, diarrhea, and other thing. We have to hold the diuretic, give 3% LACL if there are severe symptoms, otherwise manage on isotonic saline, correct serum potassium, and we have to check for sodium monitoring and check for overcorrection because there can be high chances of ODS. So this is how we have to approach if this diuretic induced. There is another entity which is called as cerebral salt wasting. Now there are certain people who say that cerebral salt wasting and SIADH are mostly synonymous with each other. They mostly have similar sort of pathophysiology, head injuries, brain injuries, meningitis, encephalitis, and other things. But they differ in one very important thing, that is volume status. In cerebral salt wasting, the person is usually hypovolemic and is having hypotension. In SIADH, the person is euvolemic. So this one important finding actually helps you find whether it is cerebral salt wasting and SIADH, because the management is totally different for both. Here we give isotonic saline, and there we use fluid restriction in SIADH. That is how the things are different. So in hypovolemic hyponatremia, we have to give 3% NaCl if very, if the symptoms are severe. However, if the symptoms are not severe, then isotonic saline is to be given. Please don't give isotonic saline to a SIADH patient. It is going to worsen the hyponatremia. So if the person is having mineralocorticoid deficiency, which is Addison's disease, then give isotonic saline for volume depletion. Glucocorticoid deficiency positive, give stress doses of hydrocortisone. So finally, concluding my talk, hyponatremia is a frequently encountered problem. Please treat hyponatremia based upon the symptoms, based upon the duration, acute or chronic. Please try to take good history, good examination to find out if the patient, and then order correct investigation, interpret them correctly. Please do ancillary or added investigations from case to case basis to find out the cause of hyponatremia. Treat hyponatremia and find the cause simultaneously. No one takes precedence over the other. And if somebody has to take precedence, then it is the treatment of severe symptom will take precedence over finding the cause of hyponatremia. So with this, I end my talk, and I thank Dr. Anubhav Prakash sir for giving me an opportunity to speak in front of all of you. Thank you, sir.
Well, thank you, Dr. Nitin, for a wonderful exposition of hyponatremia, which is one of the commonest electrolyte abnormalities that we see in our wards, and how to manage it and approach it. So, do we have any queries? Let me check the chat box if we have any. Mannitol causes hyponatremia or hypernatremia?
Okay. Sir, mannitol most commonly causes hyponatremia. It is a hyperosmolar agent. It can lead to hyperosmolarity. So it can lead to hypertonic hyponatremia.
So, what mannitol does is it takes out the water content. So, that is the problem, but it also adds ineffective osmoles. So, that is the problem with hyponatremia. Any other queries? Well, all of you will need to go and read this topic again, because it is a very interesting topic and Dr. Nitin has tried to make it very simple also, and it is effectively very important for all of us to manage this, because sodium homeostasis is one of the most important things that we need to take care, not only in hyponatremia but otherwise also. So there is one query: any role for nodosis, treatment of ODS? Any comments, Dr. Nitin?
The nodosis per se for hyponatremia, it is basically bicarbonate. So it is mainly given for acidosis.
Yes.
So that is, it is not for correcting hyponatremia. It is for a totally different reason, and it is used in CKD patients to correct acidosis. And normally the criteria as per the current KDIGO guidelines is that we have to give nodosis to make the bicarbonate to around 21 or 22 milliequivalents, and then we have to stop nodosis in CKD.
Fine, absolutely fine. Treatment of ODS, I think you have covered it. Just a brief line would do.
The treatment of ODS are mainly is mainly symptomatic. So something which has already occurred. So we need to just give him symptomatic management. So that is it.
Yes, so it is an irreversible thing. You should just hope that the damage is limited to a very small setup, because once it is there, then it is not treatable. So it is more preventable. That is why we are all very cautious about preventing osmotic demyelination syndrome. For how many days should fluid restriction be tried before deciding to switch to tolvaptan?
Okay, sir, I probably knew that this would come, but actually I could not find a specific amount of duration for which it is tried. So I think what we normally follow is that we can give them around 4 to 5 days time, or maybe 5 to 6 days time, and then we can see. Unless and until the patient is having severe symptoms, then the treatment would be totally different. But here, if there is time, we can give them 5 to 6 days time. But actually, I could not find anywhere if any specific time period is mentioned for this.
Well, I think those questions are answered. You are mannitol, you have shown also. I think that is what corrected serum sodium equal to measured plus 2.4. Yes. So, shall we call it a day, Dr. Nitin?
Sir, as you say, sir.
Well, thank you so much, and thank you to all the participants for being attentive and participating. And yes, it is wonderful having senior professors deliberating upon various topics which are very important in day to day practice. So thanks to Dean Dr. Kamlesh Tiwari, his team, Dr. Jha is always there, who keep a track on and tab on the speakers and the program, and all of you participants who are very actively listening and trying to solve your queries and becoming enriching your knowledge in the process. Well, thank you so much. Thank you once again, Dr. Nitin, and
Thank you,
thank you,
sir.
everybody.
Thank you, sir. Thank you, sir.
We'll meet again next week, same time. Thank you.
Thank you, sir. Thank you.